Hello everyone, my name is Jasmine and I am a surgical tech student here today to tell you the ins and outs of a total hip arthroplasty. In this presentation, I will be taking you through quite a few things actually. We will go over the definition of a total hip replacement, the history of development of a total hip replacement, the benefits versus the risks of the procedure, the effectiveness and outcomes of the procedure, reasonings and causes as to why someone would need this type of surgery. I'll take you through some of the statistics of the procedure. We'll meet the surgical team involved. We'll go over some equipment, instruments, and the prosthesis used during the surgery. We'll go in the ins and outs of pre-op, post-op, and the recovery process, and you'll get a full breakdown of what to expect during the surgery. So let's go ahead and begin with getting a general understanding of what a total hip arthroplasty is. I don't want to lose you guys during this presentation. There is a lot of information. So let's just kind of break this down and see what we're talking about today. A total hip arthroplasty is also known as or referred to as a total hip replacement. The definition is a surgical procedure in which the hip joint is replaced with a prosthetic implant due to worn or damaged bone and/or cartilage. If you see here on the screen, your left side is highlighted with yellow, and it is surrounding our hip joint, which is considered a ball and socket joint. So the socket is the piece on our pelvic bone that has the head of the femur, which is considered the ball, just nicely nestled into that little socket there. So this is the joint that we will be discussing throughout the presentation, and is also the joint that is manipulated throughout the surgery. Now that we have a general understanding of what area of the body we will be working with and exactly what we're going to be doing with it, let's go over how do we know how to do this? Let's go over the history of it. So starting back to 1891, Professor Gluck was the earliest recorded attemptee at a hip replacement. This happened in Germany, and I will get into that story here in just a moment. Moving into 1925, an American surgeon, Dr. Marius Smith Peterson, created the first mold arthroplasty out of glass. In 1953, an English surgeon, Dr. George McGee, was the first to use a metal-on-metal prosthesis on a regular basis. In the 1960s, coming up on a little more recent to what we know, an orthopedic surgeon, Sir John Charnley, who is considered the father of the modern-day total hip arthroplasty, designed the low-friction arthroplasty. We'll get into that more in a moment as well. Today, the total hip arthroplasty is quoted as one of the most successful and cost-effective procedures in orthopedic surgery. So jumping a little more in depth to those dates that we just discussed, back in 1891, if you remember, Dr. Gluck, who was the first one to attempt a hip replacement, presented the use of ivory for the hip replacement procedure. During this time, it was a common procedure for patients whose hip joints were being destroyed by diseases such as tuberculosis. In 1925, the glass mold entailed a hollow hemisphere that fit over the femoral head, that ball part of the femur, making it a smooth surface for movement. Unfortunately, the material failed to endure the forces created at the hip joint. I'm sure you could imagine how much force we put on our hips and our femurs. Glass would be a hard one to ensure keeps a stable and sturdy support system for our structure. Later, a trial of stainless steel, which is the current metal of choice in today's THAs, was fitted into bone with bolts and screws. Moving into 1953, when Dr. McGee began by using a cemented prosthetic known as the Thompson stem and replaced the acetabulum with a chrome socket. Together, these prosthetics showed a survival rate of 74% over the span of 28 years, which I feel like back then, for only have gone through a few stages of progress, is pretty good survival rate. Although Dr. McGee's alterations had good outcomes, the method became unpopular in the mid-70s due to the visible effects from the metal particles during revision surgery. So after the span of 10 to 20 years of people who have the hip replacement, usually they need to go back in, readjust, refit, and just make sure that everything in the hip is going okay. So during that revision surgery, they were actually noticing metal particles and fragments that were splitting away from the prosthesis. In the 1960s, the low-friction arthroplasty that was designed consisted of 3 parts: the metal femoral stem, which was inserted into the actual femur, the polyethylene acetabular component, and the acrylic bone cement, which is used for the socket part of the joint that's connected to our pelvic bone, if you remember, all of which are indistinguishable to what is used in today's hip replacement procedures. Today, techniques are now standardized. However, the variety of techniques that are currently being used are an attempt to find the combination of material that carries the fewest complications and best long-term subsistence. For example, what's used in ORs today is the metal-on-metal prosthesis, metal on polyethylene, or ceramic on ceramic. So now that we have a good understanding of the history and development of a total hip arthroplasty, let's talk about why a patient may need one. If you can see on the slide here, the damaged cartilage and ball and socket joint together, some conditions such as osteoarthritis, rheumatoid arthritis, osteonecrosis, these types of conditions could warrant necessary surgery due to the effects that the conditions have on the joint itself. If patients don't have any of those conditions, it's also recommended that the surgery be done if the patients have symptoms of hip pain that is persistent or worsening over time, interfering with daily living, such as walking up and down stairs, bending over to get anything, sitting down is painful, laying down is painful. Any type of just constant pain to the area, this could definitely help relieve that pain. affects the ability to bear weight, and as mentioned before, makes repositioning difficult. So if you are anything like me and think that, okay, yeah, total hip replacement sounds great and all, but what's the catch? Today, we will go over the benefits and risks of the surgery and what's the worst that could happen. Some of the benefits include reduction of pain, increase in mobility, increase in strength. It can reduce the risk of worsening chronic health conditions such as that osteoarthritis and rheumatoid arthritis that we discussed in the last slide. It can help improve coordination, which if you have an elderly patient who falls frequently and their coordination and stability is off, a hip replacement may help them stabilize and hopefully prevent from any further falling. Also, a benefit would be the ability to maintain a healthy and active lifestyle. So, a lot of people who are in excruciating pain and are disabled from that pain end up in a mental health state of mind, such as depression, and they feel helpless because they're not able to really do anything for themselves or help. So, reducing the pain and increasing the mobility and the strength will help someone maintain and achieve that healthy and active lifestyle and avoid the mental health issues that come with that. Now that we've talked about all the good stuff, let's talk about all the negatives. Some of the risks included in a total hip arthroplasty kind of coincide with the risks of a general surgery, across the board surgery. So in that case, you'll get the formation of blood clots or the possible formation of blood clots because of that some stagnant blood during the procedure, which is why a lot of patients are put into the Pacu, the Post-Anesthesia Care unit, during post-op, just to ensure that your body is able to maintain and go back to the normal flow and system of how the system works. Also, another risk is a surgical site infection. So before you go in for this procedure, your surgeon will start you on a round of antibiotics, specifically to help that process of avoiding infection and a speedy recovery. Although this does not guarantee that you will not have an infection, the possibility is still there. Fractures during surgeries. So it may be hard to believe, but during orthopedic surgery, we are using drills and mallets. So that extra force needed to put that prosthesis into the femur or the socket, the acetabulum, may or may not cause further fracturing of the bone, depending on how fragile that area is. If there ever is a fracture made during the surgery, it can be attended to by your surgeon and or can heal itself during the healing process for your prosthesis. Over time, studies show that the prosthesis can loosen if your bone does not grow over the prosthesis as projected. Then sometimes that prosthesis can become a little loose in the socket. And if the cement sometimes used in procedures does not hold that prosthesis as expected, that can cause some looseness as well. With looseness comes pain, with pain comes uncomfortability, and then a domino effect of the worst that could happen. Like any surgery, cutting into the skin and into the body is trauma to the body, which can cause some nerve damage, especially going back to that loosening of the prosthesis. If anything, in the prosthetic or joint area that is rubbing against any nerves can cause nerve damage, and one may not notice this until sometimes years into the post-surgery life. Some patients have complained and noticed a change in leg length. Now, if you're like me and don't have a hip prosthesis but still have uneven legs, you'll know quite a little bit about this. It can be treated just by normal adjustments and stretching. However, a lot of patients don't truly notice a difference in their daily living because of the change in length, but it can be helped during physical therapy. And last but not least, the possible need for additional surgeries. Like we discussed a couple slides ago, revision surgeries are sometimes recommended at the 10 or 20-year mark just to ensure that everything is moving smoothly and making sure that there's no infection to the joint area, making sure that your prosthesis is still attached and rotating correctly. Sometimes some of the pieces need to be replaced due to wear and tear, etc., etc. Okay, moving into statistics. So for the folks that looked at the last slide and said, you know what, the benefits outweigh the risks, let's go forward with the surgery. We are talking about those people right now. So over 1 million patients in America undergo a total hip replacement every year. Over 1 million people. That is crazy. The 10-year prosthetic implant survival rate is at 95%, and the 20-year prosthetic implant survival rate is at 85%. If you remember back to the beginning of the presentation during the history and development, those statistics were only in the 70%. So we have definitely gone up in survival rate. We are very, very close to 100%, but we are in the medical field and nothing is ever perfect and is always working to get better. But I think 95% survival rate and an 85% survival rate are just astonishing for 10 and 20-year prosthetic implants. So looking at 2010, there were 1,231,209 patients under the age of 70 who received a total hip replacement. Now, this is back in 2010. I did find a few statistics as of recent in 2021. However, all of them did not give an exact number like we have here from 2010. It just showed that over millions of people have done it. So I wanted to kind of break that down for you and show you just how many people under the age of 70 can receive a procedure like this. And patients in 2010 that were over the age of 70, there were 1,321,606 patients who received that total hip replacement. Okay, enough with the numbers. Let's move into meeting your surgical team and specialists. So to start off with your orthopedic surgeon, who you will know because he or she will be the one that schedules this surgical date for you, comes up with the best plan of action for your needs, and will be the main doctor performing your procedure. Your orthopedic surgeon will be accompanied by an anesthesiologist and their techs who are responsible for ensuring that you stay stable and safe while under general anesthesia and while being worked on during the procedure. Also, you will have a second set of hands, whether that be from a physician assistant, nurse practitioner, or first assist. These staff members are there to make sure that your surgeon has the extra hands that he or she may need to efficiently perform your surgery. There is a surgical nurse that is also in the operating room along with your team, who's responsible for documenting everything that goes on while everyone else is basically predisposed into your hip joint. The surgical nurse is responsible for making sure that the sterile surgical team has everything that they need when it's not within their reach. Also, you'll have a surgical technologist who will be me in the future, and they are responsible for setting up the operating room before you come in to have your procedure, and they are responsible for making sure that your surgeon has all of the correct tools and all of the correct material and supplies needed to perform and the entirety of your surgery. And like we discussed a couple slides ago, after you are done with your procedure, you will be taken to the Pacu, the Post-Anesthesia Care unit, where you will meet nurses and staff who are responsible for looking out for you and ensuring that your body gets back to functioning the way that it is supposed to after your surgery, making sure that there are no complications, and if there are complications, that they are resolved in a safe manner. And we will get into this here in a little bit, but physical therapists and occupational therapists are the healthcare team that help you during the recovery process. They will be the ones responsible for teaching you exercises and teaching you how to get around and move with your new hip, teaching you the range of motion, the do's and don'ts with your new hip, and all that nitty-gritty. Okay, guys, we're making our way into the fun parts of this presentation. So let's talk a bit about the prosthesis that's going to be used during a total hip arthroplasty. So again, during a total hip replacement, the damaged joint is replaced with artificial parts. Those are comprised of two components: the ceramic ball that attaches to a metal stem, which is then inserted into the femur for stability, as you can see in the above images. The one on the far left shows the cup liner, the head or the ball part of the prosthesis, and then the stem, which is inserted into the femur bone for stability. The second part is the metal cup with an inner plastic layer, which is that cup liner, that attaches to the socket part of the hip joint or the acetabulum. Go ahead and take a look at the pictures above. The picture on the far right shows you what the bone and joint will look like as it's prepared by your surgeon. So you'll see the pelvis bone there, you have your acetabulum socket, and then you'll see that the head of the femur is being prepared by removing that ball joint and replacing it with the stem of the prosthesis to get the end result, which is here on the far right, of a perfect, perfectly centered and rotatable new hip. So now that we know what your new hip is going to be comprised of, I wanted to tell you a little bit about the equipment and instruments used during your operation. So some of the instruments, like we talked about earlier with the possible fractures that can happen during the operation, we use orthopedic mallets, retractors, which hold your skin back for easier visualization of the surgical site, tissue forceps, which help with grabbing the skin and tissue to manipulate for either easier access or anything like that. An orthopedic drill to secure any of the prosthesis components, or for like bolts and screws. Orthopedic chisels and osteotomes, which are little, kind of look like little nail files that you can scrape stuff off of the bones. Sterile markers, which tell your surgeon where to cut and basically keep track of what pieces of the body we're working with. Self-retaining retractors are also used. So instead of having those hands that will be working on you during your procedure being tied up by holding stuff, there's a retractor that actually does it itself. You can attach it and let go, and it will hold everything open while your surgeon is able to do it with two hands, to do your procedure with two hands. Also, we have curettes, hooks, orthopedic pliers. We are working with bones, so we have a lot of like heavy duty equipment and instruments, spreaders, and more. There's much more to the specialty instruments, but these are just kind of a breakdown of what your surgeon will be working on you with. Some of the operative equipment, like I said, bolts and screws to secure your prosthesis, pins and plates may be used. Your surgeon will use radiographic imaging like an x-ray to make sure that your prosthesis is in the correct position. Your vital sign monitors, which is what your anesthesiologist and anesthesia techs will be in charge of monitoring while you're under general anesthesia. The bone cement, which is used to secure the prosthesis, pneumatic tourniquets to help with blood flow, the general anesthesia unit, electrosurgical unit, which is your bovie. It helps cauterize and cut through the skin tissues and layers. The OR lights for better visualization, and suction to keep that surgical site clear of any fluids. Let's talk a little bit about what to expect during the pre-op stage of your surgical date. So once you discuss with your surgeon what it is you will be doing and what type of procedure and when that procedure will take place, your surgeon will give you a bit of homework. So usually with this, once the surgery date is set, you begin your pre-op prep, which includes getting a medical evaluation by your primary care doctor or your family provider. And then you will receive some blood work to get done. You'll get an EKG, which is a graph that shows your heart activity, the electrical pulses of your heart to ensure that there's no underlying problems with your heart, a stress test, a chest x-ray to ensure there's no disease in the lungs before you undergo general anesthesia, a urine sample to ensure that there's no infection. All of this will tell your surgeon if your body is healthy enough to undergo the procedure. On surgery day, you may be asked health history questions, such as if you have any advance directives, like a medical power of attorney, a living will, a do not resuscitate. Because this is a surgery, the healthcare staff just need to make sure that all bases are covered, and should the unexpected or the worst possible event that could happen in the OR happens, we need to know what your wishes are and how to proceed. They will also ask if you have any dietary restrictions or allergies, as you may be staying in the hospital possibly for a couple of days post-surgery, just to ensure that there are no complications. And when we do feed you during those days, we need to make sure that we're not going to kill you by giving you anything you're allergic to. And also medication allergies, but food is more important, wink, wink. We'll discuss your medical conditions, any chronic illnesses that we discussed earlier, all of the medications that you're taking, and any prior surgeries for your health history. You may be asked to donate blood prior to your surgery, just in case of any excess blood loss during the procedure. Your surgical team just wants to ensure that you'll have the option for restorative measures. And also, excess weight can increase the risk of infection or other complications during surgery. So your surgeon may request for you to increase healthy eating habits and promote daily exercise in the months or weeks or days leading up to your surgery. Okay, you guys, so you have completed your pre-op homework and it is surgery day. You have arrived at your surgical facility and are being taken back to the OR. And once you are in the operating room, you will be hooked up with an IV line, which is an intravenous line. This will be to give you any type of antibiotics, medications, any fluids, any blood may be needed. That's what that IV line will be for. And in some cases, a urinary catheter is inserted during the surgery. Step 2 is your anesthesia. So you may receive 1 or 2 types of anesthesia for this procedure. One would be general anesthesia, which is what I have brought up throughout this presentation, which is a numbing of your, well, basically like a numbing of your whole body. It's when you're put to sleep. So that way you don't really remember anything that goes on while the doctor's cutting you open. The second type of anesthesia that you could receive is an epidural, which is just the numbing of the waist and down. So basically from your umbilical region down to your toes will be numbed off, but you will still be awake for the procedure. Step 3 will be the initial cut. Once you're positioned to allow your surgeon access to the hip joint, your surgeon will create the first cut to begin your surgery. Step 4, once your surgeon has reached the hip joint, they will remove the head of the femur, or that ball part of the joint, and then create an opening through the center of the femur to hold the stem of the ball prosthesis. Like we saw in those pictures a couple slides ago, it goes right down the middle of the femur for stability. The fifth step, your surgeon will then remove the damaged bone or cartilage out of the acetabulum or that socket part of the pelvic bone, and then attach that cup and cup liner prosthesis to that portion of your hip. Once everything is put together, step 6 will be movement. Once the prosthesis is in place, your surgeon will rotate your hip to ensure your range of motion works correctly with your new joint. Step 7 would be to close you up. If everything is looking good, your doctor will suture all of your subcutaneous layers back together, all those underlying skin tissues and everything like that. And then usually with this procedure, the outermost layer of skin will be closed with surgical glue. So many patients don't have to worry about having any type of stitches removed after the surgery. And then step 8 is that Pacu, once again, the post-anesthesia care unit. Once the surgery is complete, you will be taken to the post-anesthesia care unit where you will be monitored for any possible post-surgery complications. Congratulations, you have successfully made it out of surgery, and we are now in the Pacu. So, for post-operative care, it begins once you are out of surgery. We have to make sure that everything in your body returns back to normal so you can return back to normal living. Your post-operative team in the Pacu will encourage you to be active and to move around as soon as possible. The more movement, the better. You want to try to avoid any type of stiffness in that area. Usually, patients will be discharged once they are able to walk, climb stairs, and change positions from sitting to standing independently. Some patients may spend time in an inpatient rehabilitation unit to prepare for independent living at home. And if they don't do the inpatient rehabilitation unit, all patients will attend physical therapy for several weeks until that muscle strength and range of motion is regained. Okay, so you have officially been discharged from your hospital and your post-op care unit, and you are on your way home and on the road to recovery. So during your recovery process, it is recommended that you ensure your surgical site stays clean and dry, take all medications prescribed to you as directed by your surgeon, attend any follow-up appointments with your surgeon, attend your physical therapy and occupational therapy sessions. It is very important that you stick to those sessions. Work on the at-home exercises as directed by your surgeon or physical therapists. Keep your legs slightly elevated to control any swelling when you're not using it. And you can use intermittent ice therapy on the surgical site to also control swelling. Usually out of surgery, you will be discharged with some paperwork that explains everything and your surgeon's preferences on how they would like you to maintain your surgical site at home. Just remember, every body is different and every person will recover differently. It is usually recommended to wait 10 to 12 weeks before returning to work or adding any light activity or lifting. Patients should be able to return to regular activities of daily living between 3 to 6 months after surgery. Post-op blues is a common emotion that patients may encounter after the surgery when there's no visible healing progress. Sometimes things like this feel like they take forever forever to fix. And I mean, 3 to 6 months is a really long time after you have a surgery done to not do anything. So it's imperative that the patient keep a positive attitude and a support group like family and friends to keep the spirits high and healing on track. Thank you guys so much for reviewing the ins and outs of a total hip arthroplasty with me. I really enjoyed putting this presentation together. Lots and lots of good information, and I hope you took something from this today. Here are a list of all of my resources. All of these websites are amazing for more than just total hip arthroplasties. Anything orthopedic you can find or medical you can find on these websites. They are really great resources to use for any type of research project. But I just wanted to thank you so much for tuning in today, and just keep me in mind and this presentation in mind if you ever need a new hip. Stay hip, stay groovy. Have a good day.